Hi, I'm Dr. Bill Gradishar, Professor of Medicine, and the Betsy Bramson Professor of Breast Oncology, Chief of Medical Oncology and Hematology at Northwestern University in Chicago. In triple negative breast cancer, we've had a paucity of novel things to offer patients that really improved outcome. It was chemotherapy, followed by more chemotherapy, followed by more chemotherapy, and just switching around the agents they were using. In the last couple of years, we've seen the emergence of not only checkpoint inhibitors, but also antibody drug conjugates that might have a role. And starting with the last first, the antibody drug conjugate sacituzumab govitecan in metastatic disease, based on the ASCEND trial, demonstrated that compared to treatment of physician's choice, sacituzumab govitecan was superior. And it didn't matter whether you were younger or older, whether you had high TROP2 expression, which is the target, or not. It didn't matter which chemotherapy drug was used as treatment of physician's choice, sacituzumab govitecan looked better. So that becomes an option for patients who've had prior therapy for metastatic disease who have triple negative disease. An equally exciting area, of course, is immunotherapy, which as a monotherapy is not particularly active in triple negative disease. But we've known for some time that when combined with chemotherapy, you get a greater effect than with either chemotherapy alone or monotherapy with the checkpoint inhibitor, assuming that patients have a PD-L1 positive disease. Now, the first drugs that were approved in this setting were the checkpoint inhibitor atezolizumab. There were two studies in PASSION 130 and 131, 130 with atezolizumab and Abraxane. And in patients with PD-L1 positive disease, the addition of atezolizumab appeared to enhance the overall outcome, improving PFS and overall survival. And then when you used paclitaxel instead of Abraxane in the 131 study, you didn't see that effect. So it was always questioned whether it was the agent, was it concurrent steroids with paclitaxel, what diminished the effect that was seen in that trial? We don't know. But all that said, very recently, atezolizumab's indication for breast cancer was withdrawn. And there's some politics behind that, including a requirement that a completely different trial needed to be done in order to maintain the indication. So a decision was made at corporate level that this was not going to be done, and as such, the drug was withdrawn. So the other trial and the other drug is pembrolizumab. And of course, there are a lot of checkpoint inhibitors that are being evaluated, but of the ones that are approved, pembrolizumab is the other. And in the metastatic disease setting, we saw that when you combine pembrolizumab with either paclitaxel, Abraxane, or gemcarbo, that you could enhance the outcome of patients with metastatic disease if they had a CPS score that was elevated. And in this population, there was an improvement in outcome to the point where we now view this as one of the appropriate choices for treating patients with triple negative disease. Those results complement the other trials that are being done in an earlier stage setting. The Keynote 522 study, which was a neoadjuvant trial of pembrolizumab with a taxane platinum regimen sequenced with an AC-like regimen, showed that you could increase the PCR rate significantly with the addition of pembrolizumab. The big question had always been, is that going to translate into an improvement in event-free survival? And there was some suggestion early on that it may. There were several interim analyses that showed, at least at one point, that perhaps the EFS was actually diminishing with longer follow-up. But with the fourth interim analysis, it was pretty clear that there was a consistent benefit for the patients who received pembrolizumab added to their chemotherapy in the neoadjuvant setting. Postoperatively, patients also receive pembrolizumab or not. And what was demonstrated is that certainly the biggest gain is in the patients who did not attain a PCR preoperatively. The addition of pembrolizumab appeared to enhance the event-free survival. Whereas in the patients who had a PCR, it wasn't as clear how much added benefit there was. And this raised the question, to this day remaining unanswered, is whether all patients need adjuvant checkpoint inhibitors if they were receiving a regimen as in the Keynote 522 study. So other trials are addressing that. The JEPR Nuevo study with durvalumab, not approved drug for breast cancer, suggested perhaps you don't need postoperative checkpoint inhibitors for all patients, but we don't have a definitive answer. Bottom line is that in patients with triple negative disease, if metastatic and they have a CPS score that's high, they would be an appropriate individual to receive chemo and a checkpoint inhibitor. In the preoperative setting, if they met the criteria for the Keynote 522 study, we would certainly consider adding pembrolizumab to neoadjuvant chemotherapy, and at least at the current time, continue it postoperatively.